Welcome back to the Deep Dive. Today we're doing something a little bit different, something special for a specific slice of our audience. We are rolling out the red carpet for the learner. So the medical students, the surgical trainees, and, honestly, the insanely curious who just want to know how the human face is actually put together.
It is a bit of a departure from our usual broad topics, but I think the source material today is just fascinating, regardless of your background. We are going to be doing a really comprehensive review and, I think, interpretation of Chapter 50.
Chapter 50, from the 28th edition of Baily and Love's Short Practice of Surgery.
That's the one.
The Bible of surgery, as so many people call it. It's the book that's probably sitting on the nightstand of every aspiring surgeon right now, causing them a fair bit of stress, I'd imagine.
Oh, absolutely. And specifically, we're tackling the chapter on developmental abnormalities of the face, mouth, and jaws, with a really heavy focus on cleft lip and palate.
Right.
And we should probably start with a very, very clear disclaimer. This conversation is not regurgitation of the text. We are not going to sit here and read the book to you.
No, if you want that, you could just buy the book. Think of this deep dive as more of a ready reckoner, maybe a revision tool or an interpretive guide.
Exactly. We're here to give you the framework.
We're here to help you understand the really critical concepts, the why, behind the what. We want to give you the hooks to hang all that detailed information on.
That's it. So I would strongly, strongly encourage you to actually read Chapter 50. You need to see the diagrams, the fine print, the x-rays.
Right.
Use this audio experience as your conceptual anchor so that when you do sit down to read the text, it all just clicks into place. You'll hear our voices in your head explaining the difficult bits.
Consider us your Sherpas up the mountain of medical text. So here's the roadmap for our journey today.
Okay.
First, we're going to navigate the alphabet soup of craniofacial classifications. It gets a little messy, but we promise we'll sort it out.
Then we're moving into what I call the crisis phase. This is neonatal management. Before we even think about what the baby looks like, we have to deal with the absolute basics. Airway and feeding. Airway and feeding. Survival.
Then we'll get into the real nuts and bolts, the anatomy of the cleft. And we've got a great metaphor for this, the broken ring, that I think really helps visualize the muscle damage.
After that, we look at the long game. This is the surgical timeline from birth all the way through to adulthood, and it really is a marathon, not a sprint.
And finally, to make sure this all sticks, we are going to introduce a fictional case study. We'll call him Baby Leo, and we'll follow him through the entire protocol from day 1 to age 18.
Sounds like a solid plan.
All right, let's jump in. Part 1, the landscape of anomalies. When you open Chapter 50 of Baily and Love, you're immediately hit with this wall of names and classifications. It feels a bit like reading a foreign language dictionary. Why is this area so confusing?
Well, the problem with craniofacial anomalies is that there just isn't one perfect system to describe them all. I mean, these are multifaceted, multifactorial conditions.
Nature is messy.
Nature is very messy. So what happened is different surgeons and researchers have come up with different ways to organize the chaos, really depending on what they need to know.
Okay, so the source text mentions a couple of big names that seem to be the pillars here. Tessier and van der Meulen. What's the difference?
It really comes down to description versus origin. So Paul Tessier, who is, often considered the father of modern craniofacial surgery, he created a classification based on numbers. It's purely descriptive.
Descriptive.
Think of it like a GPS system.
A GPS system.
Yes. You have a cleft, number 0, a number 14, and number 7. It tells you exactly where the cleft is on the face relative to the eyes, the nose, the mouth.
So it's coordinates.
It's just coordinates. It doesn't tell you why it happened or how it happened. It just gives the surgeon the exact location of the defect. It's a map.
Okay, so Tessier is the map grid. There is a gap at coordinate 7. What about van der Meulen?
Van der Meulen is more like a history book. His system is based on embryology.
The why.
The why. It tries to pinpoint when and where development went wrong in the womb. He breaks it down into, the failure or fusion of these different processes or the abnormal formation of bone. It's about the story of the error, not just its final location.
This brings us to some vocabulary that Baily and Love throws at the reader right out of the gate.
Yeah.
And we really need to define these terms because they are the building blocks for the entire chapter.
Absolutely.
Let's break them down. First one, clefting.
Clefting is, mechanically speaking, pretty straightforward. It is a failure of fusion. The blueprint was there, the parts were there, but they just didn't connect.
Okay.
Imagine two tectonic plates that were supposed to slide together to form a continent, but they stop short. That gap between them, that's a cleft.
A gap where two walls didn't meet.
Okay.
Okay. Next up, a pair that I think often tricks people up. Dysostosis and dyschondrosis.
Right, so this refers to the materials themselves. If clefting is a gap between good parts, dysostosis is, well, it's bad building material. Bad bricks. Dust means bad. Ostosis means bone formation. So it's the abnormal formation of bone. Dyschondrosis is the exact same concept, but for cartilage.
So sticking with that construction analogy, clefting is a gap where two walls didn't meet. Dysostosis is when the bricks themselves are crumbly or misshapen.
That is a perfect way to visualize it. And then we have the third term, which effectively sounds like the complete opposite of clefting, synostosis.
Right, craniosynostosis.
Exactly. So synostosis is premature fusion. The sutures, which are like the expansion joints between the skull bones, they weld themselves together way too early.
Ah, so it restricts growth.
Totally. So if clefting is a door that won't close, synostosis is a door that slammed shut and locked way too soon while the room was still being built.
And the brain is still trying to grow inside that locked room.
Precisely. So the brain is pushing, and because the door is locked, the skull has to expand somewhere else. It bulges out in the direction of the sutures that are still open, which is what gives you those characteristic head shapes.
That is a really helpful way to visualize it. Now, the text also mentions something called the omens classification. Is that a catch-all for everything?
No, and this is a classic trap for medical students. Omens is a specific acronym, and it's used only for hemifacial microsomia.
Okay, so just for that one condition.
Just for that, it's a condition where one side of the face is underdeveloped.
And what does it stand for?
It's orbital, mandibular, ear, nerve, and soft tissue. It just helps the team grade how severe that specific condition is on a scale. But please, if you're in an exam, do not use omens to describe a standard cleft lip.
You'll get 0 points.
0 points. It's the wrong tool for the job.
Good tip. Let's talk numbers for a second. The epidemiology snapshot. How common are these things?
Cleft lip and palate are surprisingly common. The text cites an incidence of approximately 1 in 600 to 1 in 700 live births.
Wow, that is common.
It is. That makes it one of the most common congenital anomalies. If you work in pediatrics or even general practice, you will see this.
Okay, and then you compare that to the syndromic synostosis, things like Apert, Cruzon, or Pfeiffer syndromes?
Oh, those are much rarer. Apert and Pfeiffer are around 1 in 100,000. Cruzon is maybe 1 in 62,500.
So, as a junior doctor, clefts are your bread and butter. You might only see an Apert syndrome once in a blue moon, or maybe only if you work in a specialist craniofacial center.
That's right.
There's an interesting gender split in the data, too, that the book points out.
Yes, this is a classic exam fact. Cleft lip and palate, the combination, is more common in males.
Okay.
However, isolated cleft palate, so just the hole in the roof of the mouth with a totally normal lip, is more common in females.
That's very strange. Do we know why?
We have some theories. They mostly involve the timing of palatal closure in male versus female embryos, but, definitive answers are still pretty elusive. It's just a very robust statistical trend you need to know.
And what about left versus right?
For unilateral cleft lip and palate, the left side is affected in about 60% of cases.
60% on the left.
Again, we don't fully know why, but for some reason the left side seems more vulnerable developmentally.
Okay, we've covered a lot of terminology very quickly there. Let's do our first check-in question.
Right. So if you're listening, just pause for a second and ask yourself this. Can you define the difference between dysostosis and synostosis?
Think about that door metaphor we used.
If you can't quite recall which one is the bad building material and which is the premature welding or the locked door, just rewind about 3 minutes. These terms frame the rest of the pathology, so you really need to have them locked down.
Moving on to part 2. The baby is born. The parents are likely anxious, maybe even in shock. But before we worry about cosmetic surgery or speech therapy years down the line, we are in the neonatal phase.
The crisis phase. And Baily and Love makes this crystal clear. The immediate priority is survival, specifically airway and feeding.
Let's start with the airway. Why would a cleft or a craniofacial anomaly actually block the airway?
It's usually about anatomy and space. It's a real estate problem. In many of these conditions, you have what's called a retropositioned maxilla. The upper jaw is just set too far back. Or you have micrognathia, a tiny mandible, a tiny lower jaw.
So there's just no room for the tongue.
There's no room for the tongue. It's a plumbing problem. The pipe is blocked by the tongue. The tongue falls backward. We call that glossoptosis. And it physically blocks the pharynx. The baby tries to breathe, but the airway is essentially corked.
That sounds absolutely terrifying. And in the syndromic cases, like Apert or Cruzon, you have this other terrifying issue, exorbitism.
That's when the eyes are bulging out, right?
Yes, because the midface is protruded, it's sunken in, and the forehead is often flat or brachycephalic. The eye sockets, the orbits are just too shallow.
So the eyeballs literally don't fit inside the skull.
They don't fit. And the danger there isn't just about how it looks.
No, it's functional. The eyelids might not be able to close behind the globe of the eye.
And if the eyelids can't close?
The cornea isn't lubricated. It dries out. You risk corneal ulceration and permanent blindness. So eye protection in these neonates is actually an airway level emergency. You have to save their vision immediately.
So how do we manage the airway in these tiny babies? Do we just rush them to surgery?
No, often gravity is our best friend. We nurse the baby prone on their stomach.
Go.
This lets the heavy tongue just fall forward, away from the back of the throat, and it opens the airway naturally.
Simple but effective.
Very. If that's not enough, we can use a nasopharyngeal airway, which is just a soft tube that goes down the nose to bypass the obstruction at the pung base.
In worst case.
In the absolute worst case scenarios, where the anatomy is just too distorted, a tracheostomy might be necessary to secure breathing.
Okay, so the baby is breathing. Now they need to eat. Why is feeding such a struggle?
Two main reasons. First, babies are obligate nasal breathers. They have to breathe through their nose while they suck. So if the nasal airway is compromised or blocked by the structural deformity, they can't breathe and eat at the same time. It's this constant stop-start cycle.
That's like trying to drink a milkshake while holding your nose.
Exactly. And secondly, there's the physics of suction. To get milk out of a breast or a bottle, you need to create a vacuum. You have to seal the oral cavity.
And with a cleft palate, there's a hole in the roof.
There's a hole. You can't create a vacuum. It's like trying to drink through a straw that has a hole in the side.
Right. You get nothing.
You get nothing. So the baby sucks and sucks and sucks, but gets no milk. It's exhausting. The text mentions this concept of energy expenditure. These babies can burn more calories trying to eat than they actually get from the milk.
So they go into a calorie deficit. They fail to thrive.
Exactly.
So what's the solution? Do we just put a feeding tube in straight away?
We try to avoid that if possible because we really want to maintain that sucking reflex. The first step is to use special teats or, more commonly, squeezy bottles.
Squeezy bottles.
Yeah, the idea is that the parent does the work. The parent squeezes the milk into the baby's mouth when they see the baby trying to swallow.
So the parents become the external vacuum pump.
That's a crucial distinction. The baby doesn't have to suck, they just have to swallow. But of course, if the airway is unsafe or they are just losing too much weight, then nasogastric, feeding a tube down the nose to the stomach, is the safety net.
Okay, the baby is stable, breathing and fed. Now we can take a breath ourselves and really look at the problem. Part 3, a deep dive into the cleft lip and palate anatomy.
This is where we need to get our mental 3D glasses on. To understand clefts, you have to understand the border. The Berlin wall of the palate is the incisive foramen.
The incisive foramen, that's that little hole in the bone right behind your two front teeth, correct?
That's the one. In embryology, that is the landmark. Everything anterior to or in front of the incisive foramen is the primary palate.
So that includes the lip.
The lip and the alveolus, which is the gum line.
And everything behind it.
Everything posterior is the secondary palate. That's the hard palate bone and the soft palate muscle. And this distinction matters because they form at different times in the womb. You can have a cleft of just the primary, just the secondary, or both. There are distinct developmental events.
Okay, let's talk about the muscle. The text describes the orbicularis, or the muscle around the lips. You have a great metaphor for this.
Right. Think of the orbicularis oris as a continuous rubber band that runs all the way around your lips.
Oh.
It allows you to pucker, to seal your mouth, to speak. In a normal face, it's a complete functional ring.
And in a cleft lip.
The ring is snapped, but here's the critical part. The rubber band doesn't just hang there loose. Muscle has tone, it's under tension.
So it pulls back.
It recoils. The muscles bunch up on the side of the cleft.
And where did it go?
They insert abnormally. Instead of running horizontally across the lip, they run up vertically and attach to the base of the nose in the piriform aperture. And this is what pulls the nose out of shape. It flares the nostril on the cleft side and rotates the septum.
So the nasal deformity isn't a separate problem. It's a direct mechanical result of that muscle snapping and pulling.
Exactly. You cannot fix the nose without first fixing the muscle ring. That's why the surgery is so much deeper than just skin.
Okay, what about the soft palate? That's muscle too.
Yes, and the key muscle there is the levator veli palatini. Its job is right there in the name. It elevates the palate, it lifts the soft palate up to close off the nose from the mouth when you talk.
So you don't sound nasal.
So you don't sound nasal. Normally, these muscles run transversely side to side like a sling or a hammock.
Right.
In a cleft palate, that sling is broken. The muscles run anteroposteriorly front to back, and they attach to the hard palate bone.
So they're actually anchoring the palate down instead of lifting it up.
Precisely. They are structurally incompetent, and that's why the cleft repair involves something called an intravelar veloplasty. You have to physically dissect those muscles, detach them from the bone, and turn them 90 degrees to recreate that functional transverse sling.
That is a brilliant visualization. The muscle direction is just wrong, and the surgery has to physically rotate it.
Correct. It's anatomical origami.
Okay, time for our check-in question 2.
This one is pure anatomy. Listener, what is the specific anatomical landmark that divides the primary palate from the secondary palate?
It's that little hole behind the front teeth.
If you didn't immediately say incisive foramen, go back and listen to that anatomy section again. That landmark defines the classification of every single cleft you will ever see.
Moving to part 4. We touched on this with the airway, but it deserves its own spotlight because it's such a classic exam topic. The Pierre-Robin sequence.
First off, note the wide sequence. It's not a syndrome.
Right, that's an important distinction.
A syndrome is a collection of symptoms with a single cause, usually genetic. A sequence is a domino effect. One thing leads to another, which leads to another.
And there's a classic triad of features. What are the big 3?
Number 1, micrognathia, a very small, undersized lower jaw. Number 2, glossoptosis. The tongue falls posteriorly because the jaw is so small. And number 3, cleft palate, usually a U-shaped cleft.
Why is the cleft U-shaped? That seems like a very specific detail.
Because it's mechanical. In the womb, the 2 palatal shelves need to swing up from the side and close in the midline.
Right.
But because the jaw was tiny, the tongue was sitting high up, physically stuck between the shelves. The palate tried to close, it hit the tongue, and it just stopped. The cleft is literally the shape of the tongue obstruction.
It makes perfect sense. The tongue was the physical barrier.
Mm-hmm.
Now, the consequence of all this is obviously severe airway obstruction.
Yeah.
How do we treat Pierre-Robin babies?
Well, it's a bit controversial, and it really depends on severity. We always start conservatively positioning them on their tummy, so prone or on their side. That works for a lot of them.
And if it doesn't?
Then we have to escalate. There's a procedure called a lepioglossopexy.
That's a fancy word.
It is. It's a fancy way of saying we surgically attach the tongue to the lower lip.
Ouch. Why would we do that?
It acts as an anchor. It pulls the tongue forward and physically prevents it from falling back and blocking the throat.
Yeah.
It's temporary, of course, just until the jaw grows enough to create its own space.
The text also mentions mandibular distraction.
Yes, literally stretching the jawbone. We surgically cut the bone and install a little screw device that slowly, day by day, lengthens the jaw, a millimeter at a time. It's highly effective, but the text notes there's a lack of consensus. Well, it's a big operation for a tiny baby, so it's usually reserved for the most severe cases where absolutely nothing else is working.
Okay, so we have survived the neonatal period. The baby is growing. Now we enter part 5, the protocol, the timeline of care.
And Baily and Love outlines a protocol that is largely based on the UK and Norwegian model. The core philosophy here is the MDT, the multidisciplinary team.
Right.
No single surgeon can fix this. You need speech therapists, orthodontists, psychologists, ENT surgeons. It really does take a village.
Let's walk through the years.
Yeah.
0 to 3 months. What's happening?
This is all about diagnosis, support for the family, getting feeding established, and hearing checks. Audiology is vital.
Why hearing?
Because cleft palate babies are very prone to glue ear, that's fluid in the middle ear. It's due to eustachian tube dysfunction. And if they can't hear properly, they can't learn to speak properly.
That makes sense. Then comes the first big surgery, between 3 and 6 months.
This is the lip repair. We are fixing the primary palate.
Why this age? Why not do it immediately at birth?
The baby needs to be robust enough for a general anesthetic. We usually follow the old rule of tens, 10 weeks old, 10 pounds in weight, and a hemoglobin of 10.
Got it.
And we want to restore that muscle ring we talked about, the orbicularis oris, as early as we can to help mold the gums and the nose into a better shape. The text really emphasizes that the muscle repair is actually more important than the skin incision itself.
Okay. Then, slightly later, between 6 and 12 months.
The palate repair. Now we're fixing the secondary palate.
Why not just do it all at once with the lip?
It's a balance between growth and function. We do the palate specifically at 6 to 12 months for speech development. You absolutely must fix the palate before the child starts learning to articulate sounds.
What happens if you wait too long?
They learn compensatory articulation. Bad habits like using glottal stops that are incredibly hard to unlearn later.
And the technique here is that IVVP we mentioned.
Yes, the intralamellar veloplasty. That's the turning the muscles move to create that functional sling.
So, lip is done, palate is done. The kid is 1 year old. Are we finished?
Oh, far from it. The early years, so ages 1 to 7, are all about monitoring. We are watching for glue ear constantly, and we're monitoring their speech very closely.
What specifically are you listening for in their speech?
We're listening for VPI vilopharyngeal incompetence.
Okay.
This is when the repaired palate acts like a leaky valve. It doesn't close tight against the back of the throat, so air escapes through the nose when they talk.
That's hypernasality.
That's the hypernasal speech. If speech therapy doesn't fix it, they might need more surgery, like a pharyngoplasty, to physically tighten that leaky valve.
Then comes a very specific milestone, somewhere between ages 8 and 11, the alveolar bone graft, or ABG.
This is a crucial concept, and it's often the one students forget. The child still has a gap in their gum, the alveolus, where the cleft was. We need to fill that with bone.
Where do you get the bone from?
Usually from the hip, the iliac crust.
But why wait until age 8 to 11? Why not just do it when they're babies and get it over with?
The timer is the canine tooth.
The tooth.
We are watching the permanent canine on X-ray, and we want to place that bone graft when the canine root is about 1/2 to 2/3 formed.
Why that specific moment?
Because the erupting tooth is an amazing biological engine. It brings its own blood supply and its own bone-forming cells. It's like a seed growing into fresh soil. We are laying down a red carpet of bone for the canine to erupt into, and as it erupts, it solidifies and turns that graft into living, solid bone.
So if you do it too early,
the graft might just resorb and disappear. If you do it too late, the tooth has nowhere to go and gets stuck. The timing is everything.
that is fascinating. The tooth is the clock.
The tooth is the clock.
Finally, the late teenage years. 16 to 19.
Orthognathic surgery. Remember how we said the maxilla, the upper jaw, is often underdeveloped in these kids?
Yes, the retroposition maxilla.
Well, the scarring from those early surgeries can restrict its growth. So by the time they are teenagers, they might look like they have a very prominent chin, but really it's because the upper jaw is stuck back. So once they stop growing, once they reach skeletal maturity, we can cut the jaw bones and move them. Usually it's a Laforti osteotomy to pull the entire upper jaw forward, correcting their bite and their facial profile.
It really is a 20-year roadmap.
It is. It's a childhood defined by these planned interventions, which is why the psychologist on the MDT is just as important as the surgeon.
Okay, let's do check-in question 3 before we get to our case study.
Listener, why do we perform the alveolar bone graft specifically between ages 8 and 11? What specific structure are we watching on the X-ray?
It's not the incisors.
It is the canine. If you don't understand why the canine root formation matters so much, just rewind and review the secondary bone grafting section. It's a favorite question for examiners because it combines anatomy, physiology, and surgical timing all in one.
Right, let's bring this all to life. We're going to construct a fictional patient. Let's call him baby Leo.
Hello, Leo.
Leo is born with a complete unilateral cleft lip and palate on the left side.
A classic presentation. 60% are on the left side, just like we said.
Step 1. Birth. Leo's mom is trying to breastfeed, but it's just not working. She's distressed. Leo is crying and losing energy.
Right. So the suction is failing because of the hole in the palate. The expert advice here from the cleft nurse specialist is, first, reassurance, this is manageable. Then, switch to a squeezy bottle. Keep Leo in an upright position.
So the mom pumps breast milk, puts it in the squeezy bottle, and helps Leo get the calories without the burnout. We're bypassing the need for suction.
Exactly.
Step 2. Leo is now 3 months old. He's gaining weight nicely. It's time for the operating room.
This is the primary lip repair. And the surgeon isn't just closing the skin, they're going deep. They are finding the snapped ends of that orbicularis oris muscle, which are pointing up towards the nose.
The broken rubber band.
They detach them, they pull them down, and they suture them together to remake that functional ring. And this immediately straightens the lip and helps pull the base of the nose into a much better, more symmetric position.
Leo looks great, but he still has that hole in the roof of his mouth. So step 3, he's now 9 months old.
Palate repair. Before he starts really babbling and saying mama and dada, we need to fix the valve for speech. So the surgeon performs an intravelar veloplasty. They find the levator veli palatini muscles, which are running the wrong way, front to back, and they rotate them to create that transverse sling.
So now Leo has the machinery for normal speech.
He has the machinery.
Step 4. Leo is 5 years old. He's starting school. But his teacher notices he sounds very nasal when he talks.
This is VPI, velopharyngeal incompetence. So the speech therapist gets involved. They might use a video fluoroscopy, which is basically an X-ray video of him talking. And on the screen, they see that even though the palate is repaired, it's a bit short, or maybe it doesn't move fast enough to seal against the throat. Air is leaking.
So what do?
He'll have intensive speech therapy first. If that doesn't work, he might need a secondary surgery, a pharyngoplasty, to physically tighten that valve at the back.
Okay. Step 5. Leo is 9 years old. He plays soccer. He's doing well in school. But he has a noticeable gap in his gum on the left side where the teeth should be.
Right. The orthodontist takes an X-ray. They see that adult canine tooth sitting high up in the bone. The root is half-formed. It's go time.
Time for the ABG.
Exactly. They take a small piece of bone from Leo's hip, they pack it into the gum gap, and over the next year, that canine tooth erupts right through the new bone, stabilizing the entire dental arch.
Step 6. Leo is now 18. He's graduating high school. But when you look at his profile, his upper jaw looks a bit flat. His lower jaw seems to stick out. He has what they call a class 3 skeletal relationship.
And that's the long-term effect of the scarring from his early surgeries. It has restricted the forward growth of his upper jaw, but he's skeletally mature now.
So the target has stopped moving.
The target has stopped moving. So the surgeon performs a Laforti osteotomy. They cut the upper jaw, they advance it forward by a centimeter or so, and plate it in its new position. And suddenly his teeth meet perfectly, and his facial profile is balanced.
And Leo is discharged from the service.
18 years of work. A massive team effort.
That really contextualizes it. It's not just fixing a lip. It is managing a life.
Absolutely.
We are nearing the end of our deep dive. Let's recap the mission. We covered the alphabet soup of classification, reminding you to check the difference between Tessier's GPS and Van der Meulen's history book.
We discussed the crisis phase of airway and feeding remembering, prone positioning, and squeezy bottles to fight that energy expenditure trap.
We visualized the anatomy, the broken ring of the orbicularis muscle, and that crucial incisive foramen landmark.
And we walked the entire timeline, from the 3-month lip repair to the 18-year jaw surgery, using the canine tooth as our lighthouse in the middle.
Before we sign off, I want to throw out a final provocative thought. The source text briefly mentions that prenatal surgery is currently experimental and, mostly involves termination of pregnancy or just waiting.
Yes, it's a real frontier.
But imagine a future where we can actually repair the cleft in utero.
Fetal wound healing is a completely different biological process. It's often scarless.
Exactly. So if we could repair the lip and palate before birth without scarring, we wouldn't just be fixing the appearance.
You might prevent the mid-face protrusion entirely.
You might prevent the speech issues from ever starting. You might eliminate the need for that entire 18-year timeline we just described.
It would completely change the psychological landscape for the family. There'd be no shock at birth, just a baby.
It's a compelling thought. It's not standard practice yet, not by a long shot, but that is where the deep science is heading.
Something to mull over.
Indeed. This was The Map. Now go read The Territory. Baily and Love, Chapter 50.
The diagrams are waiting for you.
Thanks for diving in with us. We'll see you on the next one.